My name is Vivek Gulati. I'm an orthopaedic consultant. I work at London Independent Hospital. I treat patients who present with hip and knee problems. I treat the full age range of patients. I treat patients with all levels of different aspirations and activity. These can include conditions that come on gradually. For example, osteoarthritis is a very common condition patients present with. That's when the cushion within the hip and knee gradually wears out over time, and patients can experience a gradual onset of symptoms. They can get stiffness, they can get reduced mobility, sometimes it can affect their sleep when it's particularly severe. It can affect the full age range, but it tends to happen later on in life. We don't know the precise cause of osteoarthritis, but we do know that it runs in families. So if you do have relatives with osteoarthritis, it is a condition to bear in mind at a younger age and to get a prompt, accurate diagnosis, because we can delay the progression by identifying it. I also deal with patients who have lots of athletic sports involved in their pastimes, who present with more sudden onset pain, for example, acute hip pain and acute knee pain. That's very common in my practice. Recently, as COVID lockdown has subsided and patients have returned to gyms which have opened and hip type training, we've seen a huge proportion of patients who've become deconditioned and therefore presenting with much more sudden onset hip pain and much more sudden onset knee pain, and an accurate diagnosis is very important for those patients in order to get them back on track and get them back doing what they enjoy doing. The hip's an interesting joint. It's a ball and socket type joint. Patients can present with hip pain which can be located at the front of the hip. It may also be located on the side of the hip, and patients can sometimes present with pain deep in their buttocks. The location of the pain is an important factor in terms of determining what could be causing it. The pain may be due to something within the joint itself, so the joint is a ball and socket lined by cartilage. Sometimes marathon runners or patients who return to excessive activity can develop small stress fractures in the bone. Patients can have early osteoarthritis like we discussed before. Sometimes patients can get disturbed blood supply to the hip head, and that can cause pain, and that's very good to identify at a very early stage because that can prevent any long-standing progression. So that's a very good diagnosis to pick up for the patients. Patients can also present with pain at the front of their hip due to problems outside the joint. So with explosive type hip training, it's common to irritate the hip flexor tendons at the front of the joint. The tendon is a structure that connects the muscle to the bone and allows our legs to move forward. That can become inflamed. So that's one of the causes at the front. Patients also experiencing pain at the side of the hip joint. That's where our gluteal buttock muscles insert. So the tendons in those areas can become partially torn. There's also a membrane which lines that area called the bursa, and that can become red hot and angry, and that's called bursitis, and that can be a very painful condition. Sometimes very strong muscular athletes can even be admitted to hospital as the pain becomes so severe. So that's a common condition. And some patients also report pain deep in their buttocks, and that can also be related to a gluteal muscle tear, but it may also be referred pain from the back. So when patients present with what they perceive to be hip pain, there is a small proportion of patients who may have back spine related pathology. So that's always something to bear in mind when assessing this cohort of patients. So when a patient does present to me at the London Independent Hospital, it's very important to get a good history from the patients, because that gives us a real idea of what could potentially be going on. So most patients do present with pain. So when we look at pain, we need to assess where is the site of the pain, where does it start, did any particular event cause it, did it come on gradually, what type of pain is it. Hip pain can often present as a dull ache when it's deep within the joint, but if it's a more muscular pain, it may be more sharp in nature. Often hip pain is worse on walking, whereas back pain, which we talked about previously, can just take place at rest. So it's important to distinguish between those two types of pain, what causes the pain to get better, how severe the pain is, how it's affecting upon the patient's quality of life. So a very detailed history is key to providing a really thorough assessment for the patient. When we look at patients with hip problems, we'll do a very thorough examination. We'll observe the patient standing, we'll observe the patient through all the different stages of their gait walking cycle. We'll assess the power of the hip abductor muscles, which can become torn through a special test called the Trendelenburg test. We'll also examine the patient lying down in order to determine the range of hip motion, because the hip moves through a variety of different arcs. We can bend the hip upwards, flexion and rotational movements. And there's also special tests we can perform. A condition which is very emerging is something called hip impingement, and that can cause pain in athletes who move their hips in certain positions due to their hips having slightly altered anatomy, where they can develop extra sort of lumps of bone on their hip heads called cam deformities, which can catch in the socket of the hip joint. We also examine the spine, because we talked about before, sometimes patients with hip pain can have repaired pain from their spine, and it's always good practice in orthopaedic surgery to examine the joint below, so we'll always examine the knee joint as well. Once we've done all these things, most commonly we'll then organise imaging. The images we tend to commonly get are x-rays to begin with, because they give us the big picture as to what's going on. They allow us to determine what the bony anatomy and architecture is. And we can also get MRI scans, which give us a much more detailed three-dimensional assessment of what's going on, and it enables us to look at all those structures within the joint, the bony structures, but also outside the joint, like the bursa that we discussed before, the gluteal muscles, the tendons at the front of the hip. So that gives us a good idea what's going on there. MRI scans are also very useful to look at the back, which may be related to the hip, to see if there's any disc prolapses or any pressure on the nerves supplying that region, which may be contributing to the pain also. Common conditions that patients may find on the MRI scan include osteoarthritis, reduced blood supply to the hip. Osteoarthritis isn't a condition where we immediately need to rush in and do surgery. It's a condition which can be managed conservatively without surgery in the first instance. So we can perform injections for the patients with special materials which supplement the joint. They're called viscolubricants. So if we imagine in arthritis, the hip becomes like a dry engine. By giving this substrate, we can re-lubricate the engine and get the joint moving again, and hence we slow down the progression of osteoarthritis. We've also got an excellent physiotherapy team here who can work with patients to strengthen the muscles around the hip joint, which stabilizes the hip joint and also slows the progression of osteoarthritis. There's other medications like codliverol, glucosamine and chondroitin, which we can also recommend in order to contribute to good joint health. Things like loss of blood supply to the joint. We have seen patients here who presented at a very early stage, and those patients have had decompression procedures which has delayed any progression of avascular necrosis. So we've avoided major surgery by identifying that condition at a very early stage. Patients that present with bursitis, which is a very common condition where patients experience pain on the side of the hip joints, they can receive injection treatments, they can receive shockwave therapy, and then we can supplement that with physiotherapy in order to stop the pain becoming chronic. So if we can get on top of pain quickly by getting a good diagnosis, we can slow down any potential for these pains to become chronic and can get patients back to their activities, which is great for their physical and overall mental global well-being. I think a consultant can definitely help you diagnose a problem. I think we often always look for conservative treatments first. I think the key take-home message for all patients from all age groups with all activity aspirations is that mobility is the key to global health for a patient. So we all need to stay mobile as much as possible. We look in the media, we all need to be doing a certain amount of steps a day. So if there is something which is impeding your mobility in your hip joint, in your knee joint, then I think a prompt diagnosis allows us to do the right physiotherapy and work on the right musculature and give the right type of injection treatments in order to get you back on track. And pain in general, unless we treat it, has the ability to become a chronic, lifelong thing. So it's very important to get that diagnosis so we follow the right management path and we treat the correct muscle group and the correct joints, which can be tailored specifically to the patient and their anatomy, rather than giving a blanket approach. I think it's all in the detail, it's all in the precision. The history, the examination, the investigation allows us to achieve that goal And at the London Independent Hospital, we've got an excellent team of hip and knee surgeons, a very good, young, dynamic cohort of surgeons. So I'd recommend anybody to see myself or any of my colleagues who are equally excellent.